and hope you enjoy your break and hope you enjoyed your sessions. Apologies if it was a bit clunky to get into the workshops. Hopefully it's going to be better this afternoon. My name is Maria. I'm one of the organizing members of this year's meeting. And with Marika, we'll be chairing this second plenary on air pollution and child health. So I'm really excited to introduce you to our speakers. We have an amazing lineup again today. And our first speaker today is going to be Professor Sinha. Thank you so much for finding time in your very busy schedule to join us. Professor Sinha is going to dive with us into the connections between air pollution, health outcomes, and child health inequalities in the UK. He's a consultant respiratory pediatrician at Alderhay Children's Hospital and an honorary associate professor in child health at the University of Liverpool, and also is the national lead for the asthma and COPD audit program and the regional asthma co-lead for the Northwest Child and Young People NHSE, and the co-director for the Lab to Life Child Health Applied Data Centre in Liverpool. Thanks again for joining us, and over to you. I'll be able to share your slides in a second.
Fabulous, thanks. So just to check, will I be able to see the slides while you share them? Because I can't remember what order I'm in.
Yes, you will.
Okay, so I can start while you're sharing the slides. So good morning, everybody. I hope you're having a lovely morning so far. It really looks like a fantastic day, and I'm sorry I won't be able to join for all of it. Thank you very much for the invitation to join in this session. I mean, each of these topics, air pollution, child poverty, and adverse child health outcomes, are things that could be a 3 to 4 hour seminar in themselves. So, but my goal really over the next 15 minutes or so was to just try and tie these things together and give some examples of some work that we've been doing and some work that we're involved with to sort of set the scene, really. Next slide, please. Yeah, and as I say, we're going to talk about air pollution and health, and then touch on some of the concepts about some groups of children being hit particularly hard. Next slide, please. I am going to, as a proudly wear my respiratory hat, and the impact of air pollution is, in the most direct sense, one on the respiratory system, because obviously the respiratory system itself is that interface between the outside world and what we breathe and what goes in our body. But there are other findings as well. We know that air pollutants can enter the bloodstream, particularly small particulate matter can enter the bloodstream and affect the way that the body develops. From that perspective, we know that blood vessels can be affected. We know the pancreas and the brain and the kidneys, all of the organs that take blood can carry air pollutants to that system. But the key thing, I think, the most urgent thing is the effect on the respiratory system. And there's good evidence now that there are direct and indirect impacts of air pollution on that. So we know that relatively small increases in particulate matter and nitrogen dioxide, so just 5 milligram per microgram cubed increase in these things, can lead to an increased risk of developing asthma by about 5%. So each step you go up, your relative risk goes up. We know that in CF, a condition where there's been quite a bit less study about air pollution, really, which is a shame. But even in cystic fibrosis, we know that increasing the rates of air pollutants by a reasonably significant amount can increase the risk of children having exacerbations and can increase the risk of children growing particular bugs that can be harmful in cystic fibrosis. And this is a condition where there's been billions of pounds of research and new treatments that target the underlying defect in CF, and yet we're still expecting children to breathe air that contains harmful pollutants. And in acute infections as well, we see that in the UK and globally, both acute and chronic exposure to air pollution can lead to increased risk of different types of infections. And what's important within that is that we often focus on acute spikes of infection. oh, on days when the air pollution is really bad, people are at risk. Actually, that sort of slightly subacute, chronic, increased cumulative exposure to air pollution is also really harmful. The best analogy I can think of is lead. We knew for a long time that lead was harmful, but recommended lead levels were so high that actually the chronic long-term effects of lead were missed in children. I think air pollution is a similar thing. Next slide, please. This is Charlotte King, who is a paediatrician in Liverpool, a trainee who did a master's with us a few years ago. And she was looking at air pollution. And this was an example of some work that she did, which was important for two reasons. So she did a systematic review of air pollution and the risk of bronchiolitis, and found that there was I think a reasonably strong association. Babies exposed to air pollution were at risk of developing bronchiolitis. But this was the first time, really, that I realised that the WHO levels are way too high. In 5 out of the 8 studies that she found in bronchiolitis, and we found this in other things as well, you see those associations happening at levels much lower than what are recommended. So harm happens to children even if you're not at the legally sort of recommended levels. Next slide, please. And so why might this happen? Well, we know that there are various effects of air pollution on the airways. We know that it damages the cells directly. It leads to immune dysfunction, free radical formation, which is harmful. We know that there are epigenetic changes. In other words, the DNA that you have can be altered. And we know that there are problems with ciliary dyskinesia. In other words, the cilia that are there in your incredibly intricate and well-developed airways to clear mucus and clear crud out of your airways don't work properly. And you have increased mucus. And this, I think, is one of the key stories in cases of air pollution-related lung disease that I've been involved with, and I think was one of the key things in Ella's case, which I think you may hear about from Rosamund in this panel. Ultimately, these things lead to allergic sensitization, inflammation, infection, and structural damage. And that structural damage is really important. And I'll come back to why this slide is relevant in a poverty talk in a second. Next slide, please. There are various mechanisms by which poverty can impact on child health and health inequalities. And one of those mechanisms is this, that poverty itself carries biological changes with it in terms of poor nutrition, stress, poor air, and poor sleep. And these lead to immune and inflammatory and metabolic and endocrine problems that lead to abnormal illness and abnormal development of organs and tissues in the body. And these get passed from child to child. And so if you tie this in with the slide that we've just seen, the pathobiology of air pollution on the lungs is not that dissimilar to the pathobiology associated with poverty. So these things are tied together at a very intricate molecular level. Next slide, please. And children are particularly vulnerable to the impact of air pollution. They're the right height to breathe traffic fumes, particularly when they're young. They spend quite a lot of time going to and from schools, which tend to be in and around main roads in urban areas. They breathe proportionally more air if you look at their tidal volumes. They have immune systems that are less well equipped to deal with air pollution, and their bodies are still developing. So their bodies will be damaged for 70 odd years, rather than adults being exposed to air pollution. There is a particular thing around children being exposed to air pollution. They make the least air pollution and they breathe the most air pollution and they suffer the effects the most. And again, if we tie this in with the last two slides, what we start to see is that the biology of air pollution related lung disease is tied with childhood, it's tied with poverty. Next slide, please. And when we think about why that lung growth is crucial, we talked about structural damage, we talked about altered organ development. We know that how your lungs are when you enter adult life will determine when you die of all causes, really. Your lung growth in childhood and in adolescence is crucial, and then you start to decline. So entering adulthood with damaged lungs puts you at risk of COPD and other lung diseases. And I think there's emerging evidence about DNA changes in lung cancer in non-smokers who've been exposed to air pollution. So the point is this, that when we think about the impact on children, yes, we can find acute impacts. Yes, we can find, sadly, mortality in children associated with air pollution. But actually, when we start to think of the bigger picture and the next 70 years of their life, the story becomes a different one. It's absolutely vast. Lung growth is crucial, and early year problems are absolutely key to a lot of the lifelong inequalities that we see. Next slide, please. So we've said that there's a bit of a vulnerability to children already. Biologically, children are vulnerable to air pollution, and the biological changes might tie in with poverty. Well, the societal changes tie in with poverty as well. There's now clear work from the UK, from the Netherlands, and from the States and other countries showing that certain groups are more exposed to air pollution. So if you look in Europe, communities where there are more than 20% of black people, even when you account for poverty, communities where there's more than 20% of black people have higher levels of air pollution in their air. And again, these are the types of levels that can lead to significant respiratory problems. Also, if you look at communities that are more deprived, you see higher levels of air pollution. So the most deprived people, and particularly black people, and I suspect certain groups of South Asian people, are exposed to air pollution more than other groups. So as well as the biological vulnerability, you start to see the societal vulnerability here. In the next slide, please. And one of the things that we always need to be very mindful of, on the left here is some work from about 10 years ago showing that between 2001 and 2011, the groups that benefited the most from air pollution reduction strategies were the richest people, and the poorest people didn't see any significant benefit. And that's not true across the board. On the right is a snapshot from a recently published paper comparing air quality management plans in the northwest of England and places that had these. We saw reductions in air pollution, and in particular, and it was a well thought through piece of work on the northwest coast, in particular, the places that had higher levels of deprivation saw the best benefits from doing this. So if you think things through, we find that you can benefit the poorest people, but you have to do that from the start, because otherwise you run the risk of the poorest people benefiting the most. Next slide, please. Okay, so we've talked about the fact that there's biological and societal vulnerability to air pollution in children and in deprived children and black children. But also what we need to bear in mind is that these things don't just occur by themselves. Okay, so this exposure to air pollution is not the only thing that children in poverty are exposed to. They've also got problems with poor sleep, poor nutrition, as we've discussed and we'll discuss. But one of the key things is that we find that adverse exposures act synergistically. They compound each other. So if you look at prenatal exposure to air pollution, particularly in the mid-trimester, what we see is that mums exposed to air pollution when they're pregnant have a higher risk of having offspring with asthma. But that's only really seen in mums who are suffering from psychological stress, and you start to see, well, different mums are at different risk from the same exposure. And when you look at indoor and outdoor air quality, we see a similar thing. So being exposed to outdoor air pollution is bad for your asthma. Being exposed to indoor air pollution is bad for your asthma. You put them together and the result is significantly higher than you would otherwise expect. So air pollution, indoor and outdoor, act synergistically, and other things will tie into this. The next slide, please. And one of those things is again the sort of the temperature of your house. This is Alice Lee, who's a paediatric registrar doing a PhD with us at the moment. This was a report that we published with Sir Michael Marmot about fuel poverty, and we've got another one coming out about food poverty in a few months' time. The key thing that we learned from here, or the key sort of thing that I took away, is that normally when we think about cold homes, we think about the elderly and vulnerable elderly people, but now the conversation is changing. We managed to shift this conversation towards thinking about children in cold homes as well. And one of the key features of cold homes is damp and mould, and that is something that very much compounds the effects of outdoor air pollution. And within this slide, you see one of the other key features of poverty and child health inequality, that families don't have enough money to bring their children up in an environment that makes sense and is safe. And I didn't realise until we did this that families in the poorest decile are spending 72 pence out of every pound just on heating their house after housing costs. And what's interesting about that is that it's exactly the same amount that decile pay on feeding their children according to government guidelines. So suddenly you find that in the poorest tenth of the country, and probably more given the current problems, we find that people are spending £1.40 out of every pound in their pocket just on heating and feeding their children. And so, next slide, please. And so what you see is that something has to give. And we've known this for a long time, and I've been saying this for a long time without the evidence to back it up, that the children who are more likely to benefit from fresh fruit and vegetables, antioxidant foods are the kids who are less likely to access them, and that would be a protective factor that's being taken away from the children who are most exposed to air pollution, as we've seen. And this was a recent piece of work from the UK Biobank study showing that in families or in people, in adults who have healthy diets with particularly vegetables, particularly vegetables, that attenuates and lessens the impact of air pollution on the risk of all-cause mortality. So we're starting to see this come true, and I'm glad it's going to feel validated. So I've been saying it for a long time, and no one's questioned it, but now we're starting to see the evidence come through to back up what we've been saying. Next slide, please. So one thing comes to about how do we address this, and this is Carl Holden, who's another PhD student of ours, who's doing some work about air purification systems in the home, and he's running this through a clean air clinic, which we started in Alderhay about nearly 18 months ago, where we see children where there's concerns about indoor or outdoor air quality and their respiratory health. And really the driver for doing this was that it enabled us to have a credibility about when we talk about air pollution and housing. We used to say, oh, please, can you send someone round to fix someone's house because I'm sat with them in clinic, and we'd be most grateful. And now we send letters like this saying, this child is at significant risk of lifelong respiratory problems, which may be fatal. Failing to address these problems in the house will impair the lung development and predispose it to these. They might reduce her life expectancy. As a matter of the utmost urgency, sort it out. There'll be potentially grave consequences. In other words, our voice in this has changed. And we're not saying, please, we'd be so grateful if in your busy life as a landlord, you may be able to fix the rising, creeping mold that's in this baby's bedroom. We now say, your house is going to kill this child. And it's the same way that we started communicating about outdoor air pollution as well. When we speak to councils, we say, children will literally die because of this. One of the things that we've talked about with Liverpool Football Club is that the group of people who live around Anfield will never, ever in a million years be able to afford a ticket to go and see the team that's absolutely in their DNA. And yet, when there's a home game, they're the people that will breathe the traffic fumes of other people going to the match. So it's really important that we think about these things in context of the gravity of the consequences. Next slide, please. Alongside this is some other work that I've been doing. I absolutely strongly believe we should end landfill sites, both for health reasons, both for just respect for working class people reasons, and for environmental reasons. Around 25% of human global warming impact is from methane, around 15% of that is from landfill sites. And when we look at the health impact of landfill sites, again, you see problems. These are only situated in places where there are working class people. And the fumes and the chemicals from landfill sites are undoubtedly harmful. I worked with this community in Stoke, who it's an ex-mining community, and their mine is now a landfill site. This child has got bronchopulmonary dysplasia and is worse than he should be, so we took the government to the High Court and said, your landfill will kill this child, and we won. And then the government appealed it not on the basis that we were wrong in what we said, but they didn't want it to be said in a court. They said that the judge had overstepped his remit in agreeing with us that that landfill sites were a threat to the lives of children. And we've been finding other landfill sites around the country where children are significantly suffering from respiratory problems. We're starting to look at the impact of this on leukemia and other health conditions. Inextricably ties with poverty. You don't see landfill sites in places where Jacob Rees-Mogg lives. You see landfill sites where working class communities live. And if you look at Southall, if you look at Belfast, if you look at places where there are high levels of other issues, you start to see other factors feeding into this. As well as poverty, you start to see issues around unregulated industry. You start to see issues around environmental racism. You start to see issues around misogyny when women speak up against the impact of industry on the environment that their children grow up in. Really important that we club behind working class communities and black communities and empower women in particular to stick up for their children. Next slide, please. And I think this is my last slide. This is what I think needs to happen. I'm thoroughly underwhelmed by governmental responses to air pollution. I think when things work, we take them away. When things don't work, we invest millions of pounds in them. And we don't listen to the voice of children. We don't listen to the voice of families. With rights come responsibilities. So the UN Convention for the Rights of the Child should be enshrined in UK law. We need better monitoring. And the reason I say that is that not only are the levels very high, as we could say there, the review of what these limits actually signify, the levels are so high, you just can't prove air pollution causes a problem because that's the level people work at. The levels need to be much lower. The monitoring needs to be much better because I'm sick of getting letters back from councils and the government and other people saying, well, we don't have the data to suggest that this has caused this problem to this child. And you go, well, it's not that child's problem that you haven't invested in getting the data, and then you're stuck. And I think, again, and I will continue to say this, that the Environmental Agency and public health bodies have a far greater role in protecting the health of children. And yet sometimes you look and we don't. We make political choices that prioritize industry over children. And the key thing is that we as paediatricians and public health practitioners who are interested in this field need to get in on those discussions. And I think that's my slides done. But thank you very much for your attention. Thank you for sharing those.
Thank you so much, Professor Sinha. That was very insightful and very vocal on the importance of considering all aspects when looking at respiratory health, including poverty and obviously air pollution. With our next speaker, we will move away from the UK and we will explore a bit more the links between air pollution and respiratory health in sub-Saharan Africa. We're very honored to host Professor Refiloe Maskela, pediatric pulmonologist, associate professor and head of Department of Pediatrics and Child Health at the University of KwaZulu-Natal in South Africa. She is also an honorary visiting professor in the Center for Genomics and Child Health at the Queen Mary University in London. And she is the principal investigator for the Acacia study for South Africa and the vice president for the Pan-African Thoracic Society. So thank you so much for joining us today. Professor Maskela has pre-recorded a talk which we will play, but she's also with us today, so she will be present to answer all your questions in the Q&A at the end. So if you want to pop your questions and comment in the chat, we will look at them later. Okay, thank you.
The talk today is respiratory health and air pollution in sub-Saharan Africa. So we've heard about impacts of air pollution and lung health in the UK, and I'll be giving a view from the sub-Saharan Africa. The overview of my talk, I'll touch on air pollution, its impact on respiratory tract infections, lung function and pollution, as well as asthma, and I'll address a few research gaps and then we can conclude. Lung health is really the ability to lead a good quality of life that is free of infections and exposures that could limit the lungs' capacity to breathe. I think that's really a very good definition. So in order for children to attain this, they should have access to vaccines to prevent them from getting respiratory tract infections, because we know from data that lung function declines with the infections that children are exposed to. They should have access to good food, so adequate nutrition. They should be free from exposures, and of course, with lung health comes a good quality of life and the ability to learn and play. Now, in the context of Africa as well and air pollution, because of the increasing urbanization of Africa, a number of health effects may be increasing with respiratory effects being highest. And this is really due to the increased exposure of people to both traffic-related pollution, because of the small spaces that people are living in. There's lots of burning of waste and rubbish, the type of cooking fuels that are used, as well as lighting sources. As people migrate away from more rural settings, there is more overcrowding, which means that exposure to, for example, tobacco smoke is also higher. And the nutrition is slightly poorer as people are not able to grow their own food, and people are also less active as they're not having to work long distances. All these effects of urbanization also impact on people's lung health. Now, the WHO recently published last year this data around air pollution as a silent killer, causing over 7 million deaths globally, and the majority of these are in low middle income countries. And you can see that in Africa, about 1 million deaths occur every year as a direct result of air pollution, and chronic respiratory diseases, pneumonia and asthma are included in this group. They also produced the air quality guideline levels, which were lower than the cutoffs that were published 15 years prior. And you can see the PM10 cutoff is now reduced to 15 micrograms per meter cube, and for PM2.5 now 5. And again, they also have new guidance on ozone cutoffs, as well as nitrogen dioxide. So what about respiratory tract infections and air pollution? We know that lower respiratory tract infections, or what is commonly referred to as community-acquired pneumonia, is really a spectrum of diseases which affects both the air as well as the lung parenchyma, and can be caused by many different etiologies, including viral infections, bacterial infections, and fungal infections in some instances. Why is pneumonia important? Pneumonia is still a very important cause of mortality in the African context. This is actually data from the Global Burden of Disease Survey published in 2019, from data from 1990 to 2019, showing that in the under 5-year-old age group, the purple area, mortality from pneumonia in children under the age of 5 declined from just under 600,000 to just about 400,000 deaths per year in sub-Saharan Africa in 2019. The majority of this, the wins from this is really related to the pneumococcal vaccine strategy, as well as people having access to antiretroviral treatment. Although we've had these gains, mortality from pneumonia is still too high and unacceptably high in sub-Saharan Africa, and there's a need to reduce this mortality burden. This is same data from the GBD survey, showing that in South Africa, one of the top 10 causes of deaths from pneumonia in children, if you look at the top 10 causes, starting with wasting is the top cause, you can see that secondhand smoking, as well as indoor pollution and use of solid fuels, are still in the top 10 causes of pneumonia deaths in South Africa. And this is the context where over 70% of the population actually has access to electricity. So this is data from the Drakenstein Child Health Study led by Hereza in Cape Town, And the SPURF cohort that has been followed from 0 to 5 years, they follow that mums, over 1,000 mums from the pregnancy through to delivery, and these children were assessed fairly regularly for new respiratory tract infections in their first 5 years of life. And the data that I'm presenting here is the number of children in the study that were actually admitted with a severe pneumonia in hospital. And here they were looking at what were the risk factors for children being hospitalized for pneumonia in this cohort. Of the over 1,000 children, only 174 episodes in 133 children. These were fairly young, around the median age of 4 months who had pneumonia. And they also looked at a number of characteristics in this population of children that were admitted with pneumonia. You can see here they also had PM10 levels for just over 100 of these children recorded. And if you look at the mean PM10 levels in this population, over half of them actually had above the 10 micrograms or the 15 micrograms per meter squared exposure in this population. And when I looked at another pollutant tooling, actually very few children had high levels of this. So when they looked at risk factors for either having a long hospital stay or death or admission to ICU, actually in the study, the level of PM10 had actually no impact in terms of severity of disease. The only factors that they found was the children who were preterm, had hypoxia, or had a very high CRP. And the mortality in this cohort was fairly low from pneumonia, only 1.7%. But just stating that this is a cohort where the HIV infection rate was very low. Only one child in the study population was actually infected. So what about interventions to prevent pneumonia, and whether we can use cleaner cooking stoves to prevent pneumonia in people who are using biomass fuels? This is started from a CAP study led by Refiloe that was done in Malawi, which is a really cluster randomized controlled trial of a number of villages where they had in the intervention arm, they gave families 2 clean cook stoves, and in the control arm, they used the usual cooking method with their biomass fuels. And the primary outcome in the study was to see the number of pneumonia episodes, IMCI pneumonia episodes in children under the age of 5, comparing the 2 groups. What were the outcomes of the study? They found that there was actually between the intervention and the control arm absolutely no difference in terms of pneumonia episodes, IMCI defined episodes between the intervention and the control arm. So this really was a negative study, no impact of pollution on or using a lower pollutant cooking method on pneumonia episodes. But they did state in the study that other sources of pollution like rubbish burning, the intervention cook stoves also had challenges with batteries, etc., that required frequent changing, and many people were also using the intervention as well as the other methods to cook their meals. So what about exposure to pollution and other respiratory diseases? This is we know that in sub-Saharan Africa, the TB burden is very high. This is a systematic review of studies looking at environmental tobacco exposure in children and impact on TB infection. And in this meta-analysis by Dafta and colleagues, they found in 10 studies, the majority in low-middle countries, only one in Spain, that 2 times risk of having TB infection in children that were exposed to tobacco smoke. Now, this is a recently published study published in Thorax in September of this year from Essen, who's based in Gambia, where they wanted to look at the impact of post-TB lung disease in children. They had cases of post-TB lung disease in just under 70 children, and the control group was children living in the same household who didn't have prior TB. And what did they find? That post-TB lung disease, children who had post-TB lung disease actually had a higher odds of ratio, almost 4 times, of having low lung function. So what about lung function and air pollution? This is not data from Africa, but was actually a very nice study done by Jonathan Gibbs group in London, where they actually wanted to look at the impact of carbon in the aerial macrophages and its impact on lung function in actually healthy children. They only had a small control a group of 9 asthmatic children. And in the study, you could see that the more black carbon there was in the air, the lower the lung function, both FEV1, FVC, as well as FEV1, F2575. So a nice correlation or association between low lung function and higher carbon content in the alveolar macrophages. Subsequently, Abby Whitehouse was Jonathan's PhD student, went to look at adult women in Malawi, also collected sputum, looking for black carbon in the sputum in the alveolar macrophages. And what they find that in patients from that CAP study that I just mentioned, those that were using traditional cook stoves versus those who were in the intervention group, they looked at the PM2.5 measures as well as CO. No difference in the two groups, but looking at the alveolar macrophage carbon, you could see that in the intervention it was lower, and they also had a small comparative group of women in the UK where the black carbon in the macrophages was very low. So really from the previous study that I've shown, if this is associated with low lung function, this is a signal that there may be an explanation of why people may have lower lung function in Africa at least. So the conclusion of the study was cleaner biomass fuels were associated with lower airway black carbon. Now, this is another study, which is called the GRAPH study, which is also another cluster randomized controlled trial intervention trial in Ghana. And this was led by Alison Lee from New York. And in the study, they actually followed up, it was also a birth cohort, where they followed up moms from 24 months of pregnancy through to, and the children were followed up through 1 year. And they looked at maternal exposure to carbon monoxide from 24 weeks onwards, and looked at pulmonary function testing in these children at day 30 of life, and also quantified lower respiratory tract infections in the first year of life. And the outcomes of the study, they found that the increased prenatal CO exposure was associated with airways obstruction in these babies, and they had also increased respiratory rate and minute ventilation. And this impact was actually higher in girls more than boys. And we know that in Africa, females are the ones who usually have to do the cooking, so that really causes a living greater risk. And they thought that why this may be so is that girls actually have more alveolarization and surfactant production earlier than the boys. What about asthma? Now, this is also data from the Drakenstein cohort study, where they actually took a subset of children, about 270 children. They collected genome-wide association studies looking for asthma genes in just over 270 children. And what were the findings of the study? When they looked at the association between particulate matter PM10 and maternal smoking with lung function, what did they find? That exposure to prenatally to PM10 impacted the functional vegetative capacity of the lungs at 1 year. And maternal smoking also reduced tidal volumes by 6 weeks. And at 1 year, the tidal volume was also lower in those children that were exposed to PM10. So exposure to pollution associated with clear lower lung function in these young infants. And when they wanted to see about the association between asthma, genetic risk scores for asthma as well as PM10 and the maternal smoking, they actually found that those children that were of Black African ethnicity had lower lung functions associated with PM10 exposure. and they had more adverse effects from the exposure to PM10. Now, this is another study that was conducted also in the Western Cape, where they actually looked at children in primary schools, and 9 to 11-year-olds. This study was actually looking at risks of asthma, poor asthma-related outcomes. They did lung function tests as well as observed nitric oxide measurements in these children, which is evidence of eosinophilic airway inflammation. Interestingly, they found that people who used kerosene for cooking, these children actually had a very high phenol level in those children that were actually exposed to kerosene, showing that this association between exposure to pollutants and eosinophilic airway inflammation. So what about other risk factors that may be associated with other exposures? This is data from the ISAC study in the 13 to 14-year-olds children, the adolescent age group. This is an analysis done by Ada Ayuk from Nigeria, where she wanted to look at analyzing the ISAC data to see if there was any environmental exposures that can influence their asthma. This is started from over almost 30,000 children, and the environmental exposures were cooking, biomass fuel exposure, the type of cooking families use, as well as environmental tobacco smoke exposure. And what were the findings of this large study? That there was a clear association between maternal smoking and more severe asthma in these adolescents. So what are the gaps that I think we still need to address? We still don't know what the impacts of household air pollution are in terms of future asthma risk, as well as lung function and the genetic effects of that. We really still need to understand how we can have harm reduction strategies, especially for children who are growing and would probably suffer more effects from the pollution. In terms of the indoor and as well as outdoor pollution. And I think we also need to have more longer-term follow-up. We've got a few birth cohorts in Africa, but we really need to get more longer-term data and follow up with these children to see what the impacts are going to be longer-term. So really, I'd like to conclude by saying that, of course, we know that in Africa, the sources of pollution are quite a lot. It's not only traffic, but this type of cooking, tobacco smoke, light sources that people use. And I think one thing that's also underappreciated is exposures from an occupation. There's in some countries, even young children are also in very dangerous occupations like mining, and these would also impact their lung health. The role of pollution on respiratory tract infections, I think the jury's out there about harm reduction and whether this will reduce the number of infections. There's a number of studies that have shown that respiratory symptoms, at least phlegm production and cough, is usually higher, but whether this is associated with pneumonia is still not clear. Lung function, I've shown the data on at least the black carbon and its impact and the higher the pollutants, and also from the data from the Balkanstein study showing that even very early on in the first year of life, there's impacts on lung function. The role of exposure, especially to tobacco smoke and asthma, is well known, but whether this impacts and its effects, of course, of tobacco smoke and lung function. And I think we should really in children be worried about COPD, because we know that the lower your lung function is usually tracked throughout life, and we'll probably have more children that later on would have COPD if there are these continuous exposures. So finally, I just wanted to touch on this is a review paper that we wrote together with Sarah Raylands. Well, really, I think things that need to be tackled in terms of exposure, we should really look at the exposure from the antenatal period, maternal exposure to pollutants. We should also look at exposures in childhood as well as early adolescence and adulthood, And I think the earlier we intervene, the likelier we'll be successful. And it's important that we do tackle air pollution, as this is a huge burden and challenge. And we'll probably have more adults in the future who have COPD. That's probably linked to prenatal as well as early childhood events that are not addressed, that are related to poor air quality. Thank you very much.
Great. Thank you very much for two really inspiring talks. Unfortunately, our third speaker, the Ella Roberta Foundation, have been unable to make it at the last minute, so we will proceed with the panel discussions. So really struck there between those two talks, the sort of the commonality between both settings, with the importance of air pollution in determining lung health across the life course and intersection with malnutrition and poverty. I think a general theme for this conference is, with most of our attendees being child health professionals, is what is the most effective way that child health professionals can use their voices to combat the impact of air pollution on adverse child lung health. Yeah.
Who do you want to go first?
Go ahead, Ian, then.
You're welcome to go first, yes.
Okay, thank you. I really enjoyed your talk, by the way. It was lovely to see that data coming through. Yeah, I mean, in terms of communicating effectively, I think we need to be strong. This stuff literally kills children, and I think we've been kind of mucking about for 30 years. I mean, climate change literally kills people, and we've been mucking about with that. I think when we get involved in discussions, one of the difficulties we have as practicing clinicians is that there's always something hanging over you about what you can and can't say. And this is going to be the wrong thing for me to say, and I guess it comes with some degree of privilege in being able to say this. But actually, you can really push the boundaries of what people tell you can and can't talk about. You can talk about what you want. You live in a democracy. You can criticize who you want. And it just is what it is. We can't be tied in with constraints that are political and stuff. We're here for children. We're all here for children. None of us are career politicians. We all do our job because we want children to have a good life. So I think we need to be stronger in what we say. We need to move it was like the landfill cases. Whenever you hear about landfill cases, people talk about smelly air. It's not smelly. It's like carcinogenic, toxic air. It's like 10 steps above how we communicate with things. So I think that's one thing. The second thing I would say is that luckily things don't work like this where you can only talk about one thing, but there is only one thing that will make a massive difference in one go to all of these things: poverty, air pollution, lung health, inequalities, all this kind of stuff. And that's empowerment of mothers at policy level and at societal level. Empowering mothers, empowering Black communities, hearing the voice of children. You see wherever you are in the world that it's problems where the world is kind of set up in a way that families, and in particular mothers, are disadvantaged at almost every step, whether it be wages, gender gap. It's largely driven by motherhood. You look at the pay gaps, it's largely driven about motherhood, but also working classness. All these kinds of things are just pervasive, absolutely in everything. And when you look at some of the places where there are real problems, Southall, for example, Alice, I mentioned our PhD student, we went down to visit Southall, and there's a mum who got in touch to say, I've got an incinerator on this side behind my house that just burns plastic. On this side, I've got a gasworks. Over there is a tarmac factory that makes tarmac for Heathrow Airport, which is literally just over there. They're building a tower block over there of flats, which are clearly for city workers who don't want to pay central London prices and want to live in Southall. These are things that people in Southall will never be able to afford. And yet when we said, well, has the community spoken up? She said, well, we're a 93% non-white council ward. Like, this is not a group of people that stick their head above the parapet. And yet these are the mothers who are dealing with the consequences of what's happening to their infants and to their children. And when she does speak up, she's labelled as having, like just being an angry woman who's blocking industrial progress and all this. It's just nonsense. We have to hear the voices of mothers. We should start to revere women, whether they're mothers or not. We should be starting to revere women rather than suppress their voices. And I think women and children are the most powerful voices when it comes to air pollution. So that would be the one thing we need to back. Our voice is not that important as paediatricians. It's not that important as doctors. It's not that important. But once we start giving evidence to academics, when we start giving evidence to filmmakers, to mothers, to community groups, that's where we get our loudest voices through someone else's mouth.
Thanks. I think just to add to that, I absolutely agree that politicians don't listen to doctors, they listen to voters. Absolutely agree with that sentiment. But I think one thing in terms of empowering individuals, which is probably slightly late in my instance, I think, once you actually educate people about what is harmful to their health, then they know that it's harmful. Because if you're a child and you've grown up in an area where burning rubbish is normal, you don't know that that is harming your health. And we've gone into schools doing workshops and really teaching people about what is pollution. Many children don't actually know where the sources of pollution are. And I think just empowering communities to know what is actually going to harm their health and the dangerous impacts that may have will actually, in a way, possibly change behavior. If you don't have electricity in your household, you may not be able to, have an alternative source of energy, but you may cook outside, you may open the windows when you do so, you may have other strategies to, reduce your harm. So I think just really empowering people, giving the knowledge about what the sources are may be impactful, because I think at least in the context where I work with, there's not many resources. Just little things can make huge impact if people actually have knowledge about harm reduction strategies.
Thank you so much. Those really inspiring words from both of you. As a trainee myself, definitely something we will aspire to put into action. So I'll just go to the chat. We've got lots of questions and actually really nice discussion going on in the chat about sharing resources and about some high-profile cases that have been in the media in the UK at the moment. So Katie Rose has asked for Ian. Ian, what do you counsel families in your clinics about avoiding the risks? Oh, actually, sorry, for both speakers. What do you counsel families in your clinics about avoiding the risks associated with air pollution? She says, we can't provide prescriptions for country living, and I find the conversation tricky.
Okay. I always talk about tobacco smoke. I think that's something that can easily be dealt with. I find that in the severe asthmatic, at least that I see, there's usually someone smoking in the house. And just getting rid of that smoker or, changing behavior around the asthmatic child, for example, that really is impactful. And people also underscore, or, it underscores the value of, other things that may be harmful to the child. So as I say, educating parents about, what is harmful to the child's health, pollution, the impact it may have, even if we're not able to completely remove the pollution. And I think Ian touched on this, children walking to school, just choosing another route where you don't have to walk around the main road. All these little strategies that don't cost anything, but may have some impact in a small way for the individual patient. I think that's what I would suggest.
Yeah, no, I think I totally agree with that. I think that's really, really important. It is difficult because there's not that much you can say, other than tell people that it's a risk, and people will find their workarounds. And that, again, it comes back to the idea that particular groups are particularly hard hit. So actually, if you take someone, who's a doctor, on a good salary, and put them walking to school on a main road and then back again. Okay, the air pollution is an issue for them, but they'll come home to a nice house and eat a nice meal. Whereas the other families where we're saying, oh, vegetables have very high antioxidant, like 30% of the poorest decile are already using food banks. People get what they're given, and it's not their fault that they're in that situation. So yeah, it is very difficult. I agree that the most tangible thing is finding try and avoid the main roads. Once you're about 100 meters or so from a main road, the risks of the air pollution do drop reasonably significantly. I'm caught about there's some advice that if the air pollution levels are high, you should stay at home. I don't say that to kids. I don't, because, Jesus, they're children and they should be playing. And there comes a risk with that air pollution, but we also need to not isolate that from all the other risks that they have in their life. So we do tell people to try and avoid, main roads and stuff. But the difficulty I have with the don't play outside when the levels are high is that in my mind, I think, and again, coming back to the last talk, I think chronic exposure to subacute levels of air pollution over every breath of the first 18 years of life, even if that doesn't hit any WHO level or whatever, is more harmful to children than going outside when it's busy once. Do you know what I mean? I think people get that balance about right, I think, more often than not. So it is very difficult. What we do say is that things that are within, I don't mean their control, I mean our control as a team. If you put the child and the parent at the centre of that team, then they're part of our team, and part of the things that are within their remit are, that we can help them get better housing or whatever it might be. But outdoor air pollution, other than engaging with citizen science and community action, is very difficult. It's very difficult. There's not that much we can really. I have said to some children to start wearing, and my terminology may be wrong here, I don't know. In Liverpool, I think it's called a snood. Is that a thing? Where you wrap something around? It's like a jumper with a thing that kind of comes up over your mouth. And I do think that barrier systems are probably more effective than not having barrier systems sometimes. So we do kind of say to people, if it is really busy and there's loads of diesel and you can smell it, try covering your mouth a little bit. But other than that, what can you do? That's the work that Carl is going to be looking at in his PhD, does air filtration systems in homes help, which it might do. It's difficult. I think we do kind of tell people to spot. We do talk to people about atypical respiratory signs for asthma symptoms. So persistent wet cough is not a feature of asthma, and a wet cough and coughing fits. This was something that we saw in Ella Kissi-Debrah's case. The persistent, really dramatic, hacking, dirty, wet cough is not a feature of asthma. So we do counsel parents to look for other signs that might not just be their asthma.
Thanks, that's both really helpful, really interesting ways to change our own practice. We have a question from Sarah Hubday asking, are that the DEFRA safe levels of air pollution are even higher than the WHO ones and are even more useless, and that the UK government is still undecided about what levels to choose. How much does government consult with health about setting those levels? And question mark, how do they get away with this? Exclamation mark.
I can sum up my views on DEFRA in some 4-letter words. I'm really disappointed with their response to a lot of things about air pollution. Not just DEFRA. I think any government arm's length body of any description is tied by what things fall into. And again, we saw with that 45 days of Liz Truss, that cost the government £30 billion and it's just swept under the carpet. We're talking about putting monitoring in, changing roads. This stuff would take a few £1 million to do properly in places where people are really vulnerable. But the initial reaction of DEFRA, and if you want a really good hour's worth of listening, so on the Guardian podcast yesterday was a podcast about crustaceans and water pollution around Teesside, which is where I grew up in the northeast of England. And if you want to understand the approaches to this stuff, just listen to that, because it's the same with air pollution, it's the same with landfill sites, it's the same with absolutely anything environment based. The focus is protecting industry. That's what it is. It's all about protecting industry and cutting corners to get away with what you can get away with. So that's how they get away with it, is that it gets wrapped. And again, I go back to Southall. I go back to this mum. She's an amazing woman. She's a campaigner for better air in Southall. And when I spoke to her, she told me two things about how she was labelled. We had a really long, 4 or 5 hour chat on the phone when she got in touch. She's an amazing woman, Angela, and she was saying that when she spoke up to their local council, they labelled her as, this is her words. She said, "There's a trope about the angry black woman that wants to, stick up for her children." She said that's how she's labelled by it. And the second thing she's labelled as is somebody getting in the way of industrial progress. This is what it comes down to. It comes down to just silencing the voice of people who know what's going on. And DEFRA are complicit in that, I think. I may need to not say that publicly, actually, because we are involved in a couple of High Court cases against DEFRA, so don't share that.
We won't, don't worry. Thank you. It's really interesting. So a question for both of you from Rebecca Rhodes. It feels like radical change is needed. What would be your thoughts or hopes as to what progress we could see in the next 5 to 10 years?
Well, I think it's quite interesting that the COP27 just happened, and what is disappointing is that the biggest polluters in the world are not willing to commit. So I think pollution is actually not an African problem. We are a big continent that produces very little pollution, but we're being told that we have to, there's money thrown at us to pollute less. So I think unless, there's a real change will only come when the whole world takes a hold of this problem and really addresses it. And, unfortunately, that's not going to be one country or one place that will make the impact. Everybody needs to, do their bit so that we can have cleaner air. So I'm not confident that in 10 years we'll have huge differences, because the biggest polluters are not interested in, doing better, which is worrying.
God, it's music to my. We should meet. We should do some stuff. I think that is music to my ears. I spoke to colleagues this morning and had exactly 100% the same conversation. Yeah, okay, we can tell, my kids not to eat Nutella, but then China, Russia, the biggest polluter. The African thing is, it's almost like it's so depressingly bad the way that we impose this stuff on countries that have less money to deal with it and contribute the least. And we see that all the time. Children make the least air pollution and the most exposed to air pollution. Africa makes the least air pollution and will be hardest hit by climate change and other problems. And the time that this really dawned on me a few years ago, when they do these baby reveals where people say the color, there's a blue or pink, this is my baby, it's going to be whatever. And someone in Russia had flown some planes across that had blue smoke coming out of it. So it was a boy, and they were like, "Way!" And everyone's like, "Oh, what an amazing thing!" And this one guy from, I think he was from Nigeria. Said, just really, this understated guy just wrote, "And yet it is me, Chiba, in rural Nigeria, who's expected to shoulder the burden of climate change reparation." And I was like, this is exactly right. happens at that level, it happens at governmental level. I think you're exactly right to say what you said. That's the thing that needs to change. And your summary of we're all in it together is completely lost at a time when we should be thinking globally, and issues about which we should be thinking globally, we automatically retreat to nationalistic, populist ideology nonsense, and people get harmed. It's a game to the people at the top. You know, that 45 days of Liz Truss has broken the country. It's a game to those people. It gets wrapped up in nationalistic ideology when the atmosphere is the same for all of us. It's just that some of us are kicking the hell out of it and other people are shouldering the burden of that. Agree. So I couldn't agree more with what you said, Prof.
You're muted. You're muted.
Sorry, everyone. Thank you so much. We've got really lots of questions on the chat, but if we just have 2 more, if that's okay, because I know you're both very busy people. Joe Piper says, Ian, do you see history repeating itself with the marketing and unregulation of e-cigarettes in the UK, often owned by tobacco companies? Any evidence of their effects on lung health?
Joe, it's nice to... Joe was with us in Liverpool. He was defected down south. Nice to hear from you, Joe. Again, it's adults before children. Vaping is a reasonably effective way of adult smokers to stop smoking. And vaping, in terms of second-hand effective vaping, is probably less than, we think that less than smoking. But why did we do, like, we threw all our eggs in that basket when actually we should have spent the time, and it's not often that I will agree with Michael Gove on many things, but he went really hard with the idea that instead of promoting vaping, why don't we just end nicotine addiction this generation? That's what's happening in other countries. You can't buy a tobacco product if you were born after 2008 or something. You just can't buy anything. You just end it. Why are we, like, we do stuff to just protect industry, don't we? The government did some work around smoking 20 years ago in Tyneside schools, and at that time there was something like, I can't remember the exact number, there was something like £1 billion of tax comes from tobacco companies, and something like about £50,000 was spent on anti-smoking approaches. So yeah, absolutely see history repeating itself. It's the same whether it's e-cigarettes, alcohol, gambling, Qatar holding the World Cup. Influence follows money, doesn't it? And if you take e-cigarettes, it's exactly the same. It's all completely owned by big tobacco. It's a very dirty system, and we just sleepwalked our way into allowing another generation to be completely nicotine addicted when we could have stopped it. And yes, there is emerging evidence about direct and indirect, short-term and long-term impacts on lung health. And Jonathan Griggs' group had done some work on bacterial infections and vaping, which look forward to seeing coming out as well, which may already be out.
Great.
Well,
thank you.
I think one word is vaping is bad. It's a gateway drug. So I don't think there's any place for it. I think it's not a harm reduction strategy. It's just introducing young people to a fancier nicotine product.
Tastier, better look, yeah, absolutely. You can vape on a plane. I know this. You can vape on a plane. It's mental. Totally agree.
And a final question for Professor Maskela. So from Arang Kiran Bakaran, I'm sorry pronouncing that incorrectly, I'm sure, regarding getting in the way of industrial progress, what strategies would you think are effective in developing countries to combat air pollution?
Well, I think there's, in terms of more low-income country settings, there's some low-hanging fruit that need to be worked on. For example, I think moving people away. What happens now with a lot of urbanization is that industry is moving to where people are living, which is completely inappropriate. I think urban planning should be better because at the moment, at least in Africa, by 2030. Over 80% of the population will be living in urban environments. So I think we need to plan better about how we structure our cities, and where industry set away from people. We still have a very high polluting industries, which are unregulated. So I think regulation is important in order to reduce harm. And I think finally is governments really need to assist here and try to give people access to cleaner energy. I'm always befuddled why we cannot get people in a continent with so much sunlight, why people cannot have access to solar energy. There's many ways to actually reduce the use of solid fuels, but I think there's just no governmental or actually strategy across the continent of how to address the sources of energy for individuals living in the continent. So I think from a strategic perspective, I think the African Union needs to really have a very good climate change discussion, which has impacted a lot of people, and how to get people energy that is clean, that is available and affordable, and better urban planning, I think.
Thanks. Really interesting. So I think we're going to sort of end for this, have a break for lunch. Thank you both so much for joining us and giving up your time. Absolutely loved having you both talk and also listening to the discussion between yourselves. And yeah, lots to take forward both for academically and to my own clinical practice. So for those of you, we are back now at 1 o'clock will be our next plenary session this afternoon. But in the meantime, we have our networking available on our online tab on your left-hand side. We can go and interact and have a chat with our organising committee and also some of the other participants. So yeah, once again, thank you so much to Professor Sinha and Professor Maskela, and we'll see you after the lunch break.
Thank you so much. Thank you.
Thanks.
Bye, everybody.